We have developed a technique called the FAST-FIXO suture technique, which is an all-inside technique, giving one the benefits of easy, reproducible placement without the need for inter-articular knot tying.
The FAST-FIXO meniscal repair system consists of a delivery needle preloaded with 2 implants, a knot pusher with integral suture cutter, diamond rasps, and a depth probe. The delivery needle is available in a straight or curved style, and each contains a preset and an adjustable depth penetration limiter and a split insertion cannula. The depth probe is used when a surgeon desires to limit the depth of needle penetration to less than 2 centimeters. It is placed over the peripheral rim of the meniscus, and a reading is taken from a point 50% between the inner rim of the meniscus and the tear. The adjustable depth penetration limiter is then cut to size and slid over the FAST-FIXO needle, making sure it is completely seated on the first needle hub. The split cannula is then slid down the shaft, with the slit oriented 90 degrees to the slot in the needle. The assembly is introduced through the appropriate portal, and the split cannula is peeled back, then slid off, exposing the implants. The first needle is carefully inserted through the tear until it is felt to pop through the meniscocapsular junction. It is oscillated slightly while being removed to strip the implant from the needle tip. The second implant is advanced to the tip of the needle by pushing the trigger completely forward. Resistance will be felt before the implant is completely advanced. Insert the second implant 4 to 5 millimeters from the first. Then remove with an oscillating motion. The suture is first tightened by hand, then loaded onto the knot pusher to countersink the knot. The wire wings on the suture threader are stabilized with the thumb and index finger as it is inserted into the knot pusher. If the threader is not available, the suture can be loaded directly in the tip of the knot pusher. With tension on the suture, the knot pusher is then advanced, tightening the repair as desired. While still maintaining tension on the suture, the trigger is actuated to cut the suture, leaving the knot countersunk below the surface of the meniscus, with a 2 to 3 millimeter tail of suture. The leg is placed in an arthroscopic leg holder and draped to provide access to the anterior and posterior aspects of the knee. It is essential that careful anatomic evaluation of the appropriate landmarks are made. We come to the anterior aspect of the knee and identify the inferior pole of the patella, the tibial tubercle, both sides of the patella ligament, the lateral joint line, and the medial joint line. The portals are placed in a vertical orientation to ensure accurate perpendicular placement of the needle across the meniscal tear. The portals lie approximately 5 millimeters off the tendon and are high enough to compress the fat pad anteriorly to avoid obscuring vision. A horizontal portal would limit the orientation of the needle and accessibility to the posterior aspect of the knee. The knee is then entered through the anterolateral portal. We now have visualization of the meniscal tear at the junction of the middle and outer thirds. It is rasped to ensure a bleeding base, maximizing meniscal healing. The FAST-FIXO delivery needle is placed in the split cannula with the curve of the needle at a 90-degree orientation to the split to prevent the needle tip from popping out of the slot. We enter the knee through the anteromedial portal. The split cannula prevents impingement of soft tissue. The cannula is then removed from the needle. We can clearly see the introduction of the needle and that the first implant is sitting flush with the bevel. The implants are placed perpendicular to the tear to aid knot sliding. A considerable force is required to pop through the meniscocapsular junction. In this case, the adjustable depth penetrator limiter sleeve has been removed, and we utilize the standard 2 centimeter depth, which is achieved with the blue sleeve. The needle is then carefully removed after a slight 5 to 10 degree oscillation to allow seating of the implant. As this is removed, all 3 sutures are seen to be in good position. Then, carefully advance the second implant to the tip of the needle using the trigger. You can see that the bevel on the implant corresponds to the bevel on the tip of the needle. It is important to verify that the implant is correctly positioned. Otherwise, it will not be released upon withdrawal of the needle. Move to a posterior position for the second implant. It is essential to ensure that there is 4 to 5 millimeters between the anterior and posterior implants in the horizontal mattress configuration. The needle is then introduced in a perpendicular orientation to the tear, and approximately 50% between the inner rim of the meniscus and the tear. Again, small oscillations are performed to ensure release of the implant. As the needle is withdrawn, the implant is released. 2 sutures are seen between the implants, and a single suture is exiting out of the knee. This will be used to tighten the sliding knot. In the split image, we can see how much tension can be placed on the 0 suture compared to the 2-0 suture that most surgeons are familiar with in this situation. The knot is tightened first by hand. The slack is removed first from one loop, then the second as the knot is tightened. Once handheld tightness has been achieved, the knot pusher is introduced. The wire wings on the suture threader are stabilized with the thumb and index finger as it is inserted into the knot pusher. The knot pusher will allow further tightening of the suture construct and countersinking of the knot. Tension is maintained while the knot is countersunk. It is important to be careful not to overtension a repair. With the tip of the pusher resting on the knot and tension on the suture, the trigger is actuated, advancing the outer sleeve. The suture is cut, leaving a 2 to 3 millimeter tail. We now see good position of the horizontal mattress suture. For a vertical mattress configuration, the FAST-FIXO curved delivery needle can be used with the preset 2 cm depth limiter, as seen here. Alternatively, the adjustable depth penetration limiter can be used and cut to the desired depth. The most superior limb is placed first. We can see the second implant is then advanced to the correct position corresponding to the bevel. The inferior portion of the vertical suture is then placed, again halfway between the tear and the inner aspect of the meniscus. It is carefully advanced. Again, one can feel the pop as it goes through the meniscocapsular junction. A slight oscillation is performed to ensure seating of the implant, and the needle is withdrawn. We can see clearly the 2 limbs of the vertical mattress configuration. The tightening limb is then pulled. The combination knot pusher suture cutter is then placed in position and can be used to further tighten the suture construct. The outer sleeve is then slid down, and a tail of 2 to 3 millimeters is left remaining. The final repair is then probed to ensure stability has been restored. This demonstration posterior medial scope view visualizes the meniscocapsular junction. Along the meniscocapsular junction, we can visualize our implant sitting in the correct position, assuring we have good protection for the neurovascular structures. Cadaveric dissection with a marking pen indicates the position of the 2 implants, showing them again sitting at the meniscocapsular junction. No tethering of the capsule is seen.
We feel that this technique has the ease of placement of the implant without the downside shown with the inside out or outside in techniques.